Hello. My name is Mark Leon. I'm Chief Department of Anesthesiology and Anesthetist Unit in Marseille, France. And today we have a fascinating topic to share together is how to identify infection and sepsis. My disclosures. Identify the disease is number one priority in the management of patients with infection and sepsis. You have to know the disease. You have to treat the disease. You have to assess the outcome of your patient. But identify the disease is the step which is more critical for the outcome of your patient. And if you miss it, your patient is going to die. So that's very important step in the management of your patient. We are going to divide this topic in two parts: diagnosing infection, look at local signs, symptoms, the contextual approach, and in the second part, diagnosing sepsis, focus on host response, organ dysfunction, which is the key point of the diagnosis of sepsis. Let's start with infection. We all know how to diagnose infections, and most people in the world know how to diagnose infection. There is some fever, there is some chills, there is some fatigue. Sometimes there is no fever, but there is still an infection. And there is some localized symptoms like swelling, pain, small organ dysfunction, redness. Clinical examination is very important. That's the key. It's still fashionable to clinically examine the patients. That's very important. The identification of the source of infection is mandatory. You cannot miss it. That's critical for the choice of the antibiotic treatment. If I don't have the source of infection, I cannot guess which is my bacteria that I target with my antibiotic. So that's critical for the antibiotic choice, and thus that's critical to reduce the inoculum. And there is some very good studies showing a strong association between the identification of the source of infection and a reduction of mortality in patients with sepsis and septic shock. In my view, that's just a quality criteria. If you have a good rate of source identification, you have some good practice. There is no doubt about that. Clinical examination is the key. In the front of a patient with fever, you have to determine the source of infection, the source of fever. You have to remove the bandage to look at the surgical site infections, for example. But we have to use modern tools to achieve this goal. And in a quasi-randomized clinical trial, we use point-of-care ultrasound in patients hospitalized in ward with organ failure, with respiratory or circulatory distress. And what we show that the performance of diagnosis was really improved using ultrasound in those patients. And this was associated with an improved outcome and less intervention in the same patients. If you have a good clinical examination, if you use ultrasound and you know the source of infection, go to CT scan and use whole body CT scan as we do in patients with trauma, and try to identify the source of your infection. As soon as you have the source of infection, which is identified, you have to remove the source. And you have a rate of time around 2 and 4 hours to remove the source of infection, if feasible. We are going to talk about biomarkers, why don't you use biomarkers? So there is some good biomarkers, but if you want to use biomarkers, we need to read this paper. It's a very important paper. Uh, Biomarkers should be used for diagnosing disease or for assess the severity of the disease or as risk assessment or prediction of drug effects. But if you want to use a biomarker as diagnosis of infection, there is no choice. There is perhaps procalcitonin to diagnose bacterial infection, but the performance of this biomarker in critically patient is much more than debatable. Indeed, there is a time effect. If a patient has any aggression like a surgical intervention, there is a change in the level of biomarker like CRP, as you can see on the left of the screen. And there is an effect of organ failure, which are frequent in patients with sepsis in ICU. And if there is a renal failure, for example, the PCT levels are going to be changed. And the interpretation of the change are difficult and challenging. So there is very good paper on that published recently in Interstitial Medicine by the group of Pedro Povoa. And unfortunately, they show that the use of biomarker for the diagnosis of infection remains really limited. But in my practice, I use them a lot to differentiate diagnosis of sepsis with, for example, bleeding or cardiogenic shock or something like this. So that's important to use them, but to know the limitation of each of them and to assess all the range of disease you can have in such a patient. Next step is into sepsis. So there is a clinical diagnosis which is quite simple for sepsis, and I like this acronym sepsis, like slurred speech or confusion, extreme shivering or muscle pain, passing no urine in a day, severe breathlessness. It feels like you are going to die, and the skin mottled or discolored. I like this acronym because that's a summary of the symptoms of sepsis. You can be more scientific and use some validated score like quick SOFA based on the respiratory rate, altermentation or systolic blood pressure, about the three signs, or source criteria. There was a debate which is a balance between quick SOFA and source criteria, and a recent meta-analysis by the group of Seraphim shows that source criteria seems to perform better than quick SOFA criteria for the diagnosis of sepsis. But I don't think that's really the problem. I think that's important to have both the signs and symptoms assessed in patients with suspected sepsis. The next step is to diagnose organ dysfunction, and you can do that very intuitively by kind of systematic approach, or you can use a score like the SOFA score, SOFA for sequential organ failure assessment score. This score was completed by the group of Florida Lancel a few years ago, and it's based on sample bedside clinical assessment of each organ: respiratory, coagulation, liver, cardiovascular, central nervous system, renal. And this is very intuitive, and you can use it without knowing you use it. Finally, the diagnosis of sepsis today is based on the 2016 definition by Mervyn Singer and colleagues, suspected infection, and SOFA score above 2 or increasing by 2 points. That's sepsis 3. And if you want to talk about septic shock, is lactate above 2 and the use of norepinephrine after adequate fluid resuscitation. In front of patients with a suspicion of septic shock, I like to rule out some diagnoses like bleeding. It is very important because I need to stop bleeding if there is any bleeding. Like cardiogenic shock, because these patients are often high risk of cardiogenic shock, and antibiotic doesn't work in cardiogenic shock. And pulmonary embolisms is also a diagnosis I should keep in mind to give anticoagulation to this patient. So I need to rule out at least these 3 diagnoses. Next, I need to assess the severity of the sepsis, and to assess the severity, I can use some score which were not done to predict the outcome. The SOFA score, the quick SOFA score were not conceived to predict the outcome, but that works a little bit as predictor of severity. But there are some clinical signs and symptoms which are very efficient, like the Mottling score. You can look at the vocals in your patient and score from 1 to 5, 1 being the smallest injuries with good outcome, and 5 being the largest injuries with the worst outcome. And which is interesting is that the Mottling score is independent of vasopressor dosage or hemodynamic variables. We can use very simple and very smart examination like the capillary refinery refill time, as developed by the group of Glenn Hernandez in Andromeda shock. And you can see that this very basic examination looking for the peripheral perfusion resuscitation predicts outcome as well as lactate can do. And finally, there is this excellent biomarker that we use all the time, the serum lactate, which is included in the definition of septic shock. It should be increased, and that's a matter of debate, but that's included in the definition. That's a marker of shock, not a marker of infection. That's not discriminating for patients with cardiogenic shock or with hemorrhagic shock. That's just a marker of tissue oxygenation and severity of the process, as you can see on the figure or in the right part of the screen. The patient dying have highest serum concentration of lactate, and the patient surviving the septic shock. There is other markers of severity like the dosage of norepinephrine or the PCO2 gap, which can reflect the quality of tissue perfusion. So, have to progress because we have so many variables to assess. We have the physical science, the medical history, we have the biological results, the image findings, the hemodynamic, respiratory, renal variables, liver variables. So, how can I compute myself all these variables? Personally, I can manage only for 3-4 5 variables maximum. I'm not alone, and you're probably not better than me. And that has been shown by very nice study publishing in psychological science. A normal human cannot process more than 4 variables. That's very important. You cannot process more than 4 variables. That's the limit of human processing capacity. So we need some tools, we need some new tools, and we need some tools like deep learning, machine learning, and artificial intelligence to help us to progress in the identification of infection and sepsis. There was this wonderful uh, study of the group of Matthew Komorowski from London, showing that the use of artificial intelligence can improve the management strategies used in patients with sepsis. And now there is this wonderful paper showing that artificial intelligence may help in prediction, diagnosis diagnosis of sepsis better than quicksilver, better than physicians, better than other scores, computing many variables and information that the single physician can do alone. So my take-home message is there is no magic bullet. Infection and sepsis are 2 different steps in the management of these patients. For infection, which is very important, is to identify the source of infection. It is a quality marker. For sepsis and septic shock is to assess the organ dysfunction, each organ dysfunction and their consequence in terms of possible outcome and management. Clinical examination, in my view, remains very important. Using new tools like ultrasound, CT scan to be included in the process. Artificial intelligence today is probably the solution to improve our performance in these patients dying from the sepsis in 20% of cases. Thank you for your attention.